would fix that, Kathy, is I could threaten to actually, on all these calls, here it is right here, I could threaten to actually get on the camera for the entire time, and the only way to get me off is actually to encourage these fellows to get on the camera. Say, look, we don't want to see Froman, so we've got to put our camera on. UJ, I'm teasing you. Go ahead. So anyway,
right.
Let's start. Doris, no other housekeeping issues, nothing else we need to know? I'm sure you want to comment about time.
Correct. So let's go ahead and get started, and we're recording.
Okay, great. So let me click on this screen sharing. Hopefully it works.
Beautiful, right? And then
can everyone see the PowerPoint?
Yes.
Yeah, we can see it.
Okay,
can you
great.
go so we can get the entire slide? And yeah, it's pretty close.
Is this good?
Wondering if you can go to full screen. Yes, you can.
Not really sure.
Yeah, I'm able. Everybody is able locally to do that for themselves.
Okay.
So we're good to go. Okay, UJ, I see how quick I learned quick though. That's
okay. Perfect.
Delighted.
All right, so I'll get started. So my name is UJ. I'm a first-year MS/neuroimmunology fellow at Johns Hopkins. So I'm excited to be here to talk about a case. And it's somewhat of a selfish talk because we would like to really get other folks' opinions on management and plan moving forward. So case presentation, go over background, and then kind of hopefully some discussion about management. Okay. Trying to advance the screen. Let's see. Next. Okay, so this is an 18-year-old Caucasian woman who initially presented with 1 week of headache and vertigo. She initially went to a local emergency department where it was noted to she was noted to have a normal examination, and she was discharged with meclizine and promethazine with a diagnosis of possible migraine. However, a few days later, her parents noted that she was pretty confused and her gait was pretty unsteady. So they brought her back to the same emergency department for evaluation. They actually hadn't seen her between the first local ED visit and 5 days later because she was living away from home for college. Here's some additional history that we obtained from the family. Her past medical history included recurrent vertigo ever since she was a young child, and she's been diagnosed with migraine variant. She also has congenital hearing loss, which was noted when she was 5 years old in preschool. Her medications included a combination oral birth control pills, as well as fluoxetine for mood. Her social history is that she is a new freshman in college studying nursing. She's never smoked or no bad habits and sexually active. She doesn't have any pertinent family history. So this was her initial evaluation in the emergency department on the second visit. Generally, she was drowsy. Otherwise, her systemic evaluation was normal. She had some abnormal mental status. Specifically, she was not oriented to date. She was somewhat perceptive and inattentive. She did have some diminished hearing bilaterally on the bedside evaluation. Yes?
Can I stop you just for 1 second? Is this exam the examination which was performed by an outside physician, or is this the derivative of your exam at this time?
It's the outside physician examination.
Okay. Yeah, because interesting that they underscore mildly diminished bilateral hearing loss, a pretty young lady, and the question was there any notation or any characterization of that? Because it would be so unusual to pick this up on an exam if it was really mild, unless the patient was complaining or somebody was really astute in asking about that. So unless it wasn't mild and it was really more conspicuous or acute in onset that she mentioned it.
Right. I think it was because when they did a past medical history evaluation, the family mentioned hearing loss, and they kind of
what about you?
That on the examination. Yeah.
Okay, perfect. Okay, good to know. Okay.
Right. Strength-wise, it was mostly full strength, although she had some mild hip flexion weakness that was symmetric bilaterally. Her sensory examination was noted to be normal. Her reflexes were brisk but symmetric, and her toes were downgoing to plantar stimulation. They did walk her a little bit, and she was noted to be ataxic. So I'm going to show the initial brain MRI that was obtained at the outside hospital. It was somewhat limited due to poor patient tolerability, but the images, some of the images we got were pretty good. So the first one on the left, can you see my arrow?
Very well.
Okay, great. So these are all axial cuts. We have a DWI, ADC, and a FLAIR sequence from left to right. And starting with the DWI, you can see some punctate areas of diffusion restriction. And it's a little bit harder to see on the ADC, but it does restrict kind of these little dark dots. She also had some hyperintense abnormal white matter on T2 and FLAIR sequences. They're located mainly in the periventricular and subcortical regions.
So, Yujie, do you want to make just one comment?
Yes.
If you go back to your prior slide on the diffusion weighted, the conspiguity of those lesions is quite striking. And then if you go to the right, which is where most of us tend to sort of, let's go to the FLAIR, Good. Well, right, yeah. So it's an example. If you look really carefully, you probably can see these sort of 4 dots, these punctate radii,
right.
but they're nowhere near the conspiguity of what you see with diffusion. So do you want to make any comment in terms of the pathobiology of those dots based on this particular signature of imaging findings?
Sure, I can do that. So anytime we see, significant
hypotheses are welcome. So yeah, right.
Oh, okay. So I'm hearing some weird ringing sounds, but anyways, so basically anytime you see both diffusion abnormalities and also kind of a FLAIR or T2 abnormalities, you want to see, is it true diffusion restriction, or is it significant white matter abnormality that's shining through? And here we think it is true diffusion restriction by looking at the ADC, and you mentioned the characteristics is very bright on the diffusion. And when it's restricted diffusion, we worry about ischemic changes. So things like infarct, we would be worried about.
Also, this is Scott Newsom. Can you hear me?
Yes.
I just want to make a quick comment. So restricted diffusion, and we've talked about this, UJ, there are certain patterns on restricted diffusion that may be able to also point you in a direction of non-ischemic changes. We talk about acute demyelinating lesions showing restricted diffusion as well. There are some tumors that show restricted diffusion. So looking at the actual pattern can also be helpful in your differential diagnosis.
It's a fabulous comment, Scott. Thank you so much for that. And I would just add one other thing, and that is, on top of that is, in standard sort of FLAIR imaging sequences, location is still important, even though the more we mask the white matter or mask the gray matter, the more we look, the more we find. But that's a really, really important point, that there's still a diversity of potential pathoetiologies. Don't get stuck on one. So, Yujie, I love the fact that you went right for the money and say, yeah, this is what we usually think about in terms of ischemia. And that does set up the differential, at least in terms of what are the things that you don't want to miss that potentially might kill your patient in terms of lurking below. So it's not just the differential, it's also its potential consequences that if you don't consider it, and we do have an underlying vascular etiology, we may be in very big trouble. So I think that's very, very important. Thanks.
Great. So there's some initial workup performed on basic systemic workup. It was notable for some mild leukocytosis anemia. Also some increased CRP and ESR were noted as well. She did undergo a lumbar puncture pretty quickly given her mental status and the abnormal imaging. It showed a lymphocytic predominant pleocytosis that was fairly mild, but besides that, her protein was significantly elevated. No opening pressure was recorded. Her oligoclonal bands were negative with a normal IgG index, and her infectious studies were negative. She also had some kind of body imaging studies done, including chest x-ray, a body CT, and a transthoracic echocardiogram. And the only notable thing was a possible mobile atrial septum that was noted on the echocardiogram. So at the outside hospital, she was briefly started on acyclovir for presumed meningoencephalitis, and she was thereafter transferred to our hospital for ongoing care. On day 2 of hospitalization, she began to report some bilateral blurry vision, at which time ophthalmology was consulted for evaluation. Her mental status was not normal at this time still, so they had some difficulty kind of assessing her bedside visual function, but per their initial note, her acuity was distance only, her fields appeared approximately normal, and her dilated bedside fundoscopy was also normal. We proceeded with a full evaluation in their clinic, including fundoscopy and fluorescein angiogram, and I'm going to show some images from her left eye, which are pretty representative of both her eyes. So this is a fundus photograph and demonstrates some retinal whitening, and you can see kind of the pale patches in her retina, and it's adjacent to her optic disc. There's some scattered cotton wool spots and some hemorrhages.
UJ, do me
as well.
You have the arrow. Could you first show the novices, the rookies in the group, show us the optic disc? Because when you said that, you were actually over the macula, even though I know you didn't mean. Show us the
Sorry
cup.
about that. Yes.
No, great. Show us the cup and the disc, and just to look at anatomic characteristics, so we know where we are.
Sure, I can do that. So, arrow keeps disappearing, but here, right here is what we were talking about.
And that's what's right there. What's anatomically that?
Oh, we have the optic nerve, optic disc.
Perfect. And then the central portion of that is part of that cup, and we talked
exactly.
Right, and this is really a photographic view. If this was in the clinic, this wouldn't be a direct, it would be more of an indirect, because you see so much retina. And I know Laura Balser's on the phone, but we also know if you see the major branch pattern, its morphology seems to come from the disc, and there are ones that go behind, but you see the net effect is to come out and then go temporally toward the macula. So this has to be the left eye, right? And then where is the macula itself and its central point of position, the fovea centralis? Got it. Right. Perfect. Okay. And so now you're pointing out what seems to be abnormal. A lot of residents and attendings may be doing well with a direct ophthalmoscope if they just get the disc itself, where a lot of the money and the meaning here is actually more peripheral, of course. So, and you have the luxury with having this photograph. So can you show us the areas of abnormality that are really conspicuous that got your attention? Because if I was just looking at the disc on a direct exam, I'd be okay. And even at this far view, I can tell you that upper, lower, nasal, and temporal, that the color of that is distinctly normal. It's a normal shape. There's no tilted disc. There's no peculiar vascular pattern. But there are things here that are really, really conspicuous, and you're going to get to them. So show us what you wanted us to see.
Sure. So talked about the whitening of the retina. So usually the retina should be kind of a pinkish orangish color. Yeah. But here you can see it's pale. Mm-hmm. And we talked also about some hemorrhages in the retina.
So the circular one down there is kind of like what people might call a blot hemorrhage, whereas if you had something that was more linear, because these the blood supply is down there in the nerve fiber layer, you might have some blood that's tracking along some of those axonal fibers from the retinal neurons, the ganglion cell neurons. So that would be more of a splinter kind of hemorrhage. But Laura, I know you're on the phone. Could you chime in a little bit with UJ, a little bit of comment about not only pale, but these sort of pale punctuated by bright white? And I heard UJ mention cotton wool. It'd be good to just know geographically and what those cotton wool punctate areas of abnormality are around. It could be, I think, germane in terms of provoking us to think about things. Laura, are you still there?
Yeah, it's a little worrisome because, you don't really see arterioles well. I mean, I feel like I see veins. I realize it's a panoptic view, so you don't see the disc in as great a detail, but there's got to be tremendous arterial narrowing to go with the fact that there's signs of ischemia here with hemorrhages, etc.
Would it be safe to say that on the vascular side of things anatomically, if you just look at this, the gestalt is immediately, this looks like some oversimplification of the vascular arborization. Where are my arterioles?
Right. Yeah. That's what I'm wondering. So
Okay.
how old is this patient again, UJ?
18.
18. Yeah. Doesn't look like MS. It's
Yeah.
very worrisome for, like you said, a vascular disorder.
Right. And UJ, I'm going to stop talking, let you continue. But the other thing is that these bright areas, these clouds or these sort of cotton wool areas tend to be predominantly areas of branching. Some of them are linear, the temporal one you can see, but there's a number of these that are associated with sort of branch morphology, which sometimes raises the suspicion of branch retinal artery issues, even though most of these are larger vessels, which are veins, as Laura's pointed out. But okay, let's keep going. This is highly abnormal, guys, right? So I hope nobody listening and watching will ever pass this as normal. This is coming out of the screen, biting your nose and not letting go. So this should get your attention.
Dr. Galetta just joined us. Let's see if he has other comments. I said, where are the arterioles? But anyway, there's a lot of...
Thanks, Steve. Additional, so this is Steve Galetta. So Steve, what do you think? UJ Wang from Hopkins, beautiful presentation thus far. Young girl, 18. And she's just...
Well, I mean, you have a vasculitic looking picture back here with sheathing that is present, obviously, on that venial there. There's blood supporting that there is also associated venous dysfunction, I think, as well. And then retinal whitening is evident around the macula.
Beautiful.
So it looks like a vasculitic process.
Okay, UJ, take us away.
Okay, great. So the second picture I'm going to show is a late phase fluorescein angiogram, also of the left eye. And what we're seeing here, I'll use this pointer here, is the leakage of the contrast coming off the retinal arterial segments, which are, again, coming off this optic disc here. And just like others have pointed out, this would indicate active inflammation, which would be consistent with a vasculitic picture. Additionally, what we're seeing here, I think someone mentioned, where are the arterioles? What we're seeing is retinal non-perfusion, kind of peripherally. So additional history, unless someone wanted to add anything about the fluorescein angiogram.
That's gorgeous. Thank you.
Okay. So on day 3 of the hospitalization, she noted that her hearing on the left side was worse than her baseline. As you remember, she has had progressively worsening hearing loss since she was 5 years old, initially thought to be congenital. On day 4 of hospitalization, she noted a diffuse rash onto her legs. I don't have a picture of this, but on the notes it was noted to be similar to livedo reticularis, which would further support what other people are saying about vasculitis.
Could you just go back one slide, just make a comment about, if you would, about livedo, or I know there are other people who are on the phone, so perhaps I can ask Lindsay, I know you're there, Lindsay Horton. In terms of what we do in MS, we've treated people for years with various symptomatic meds. What medicine do you usually think of in an MS patient who presents with livedo reticularis, who you might be treating symptomatically for particular vexing problems like fatigue? And when you see this, obviously not all livedo reticularis is Sneddon syndrome or lupus or an antiphospholipid syndrome, and they're nuanced from mild to moderate to severe. But Lindsay, in your practice, if it's a young patient coming in you're treating and you see livedo, what would be your first choice in terms of thinking about etiology?
Hello, can you hear me?
Yes, yes.
So the question was in terms of side effects of disease-modifying therapy. Is that the question?
Or what particular treatment intervention? We know livedo is non-specific. It can be associated with connective tissue disorders. It can be associated with antiphospholipid syndrome, Sneddon syndrome with risk of stroke, and of course it can be associated with particular medicines. Now, we are an MS neuroimmunology club here, and so I just want to make sure, particularly for the younger folks who are not from the dark ages like Tree and I and others, that certain medications can produce livedo that is virtually indistinguishable from libido involved in connective tissue diseases. Of course, if you look at this, I'm not saying it's a red herring, but if you look at libido and you go off and say, oh, this equals whatever else you're thinking about, collagen vascular, lupus, or whatever, you may drop your anchor in deep water, except the patient says, you know, Lindsay, I saw you last month and I love you and you gave me this medicine and I'm terrific, it's great, but I've got this problem on my legs.
I haven't seen it personally, but it's been described with amantadine.
There you go, bingo.
Okay.
You go, girl. That's right. The most common. And for those of you who think that's trivial, like why did I even bring this up? Let me tell you how conspicuously not trivial it is. Very briefly. Dallas Cowboy cheerleader, a retired one, nevertheless, looking great, goes on this drug with us about 17, 20 years ago, develops libido in the legs, great for fatigue, stop the amantadine, that libido did not go away. So it can or it may not. So of the drugs we think about using for fatigue management in MS patients, there are a variety of psychostimulants, others, and amantadine can work, but watch out. Libido is common, and in some people, it doesn't go away. If you're a Dallas Cowboy cheerleader, and last year you made $1 million modeling pantyhose and high heel shoes, and now you've got this reticular vascular fishnet on your legs, you've got some explaining to do. So I want to put it out there because this is not rare. This is very common.
There
Okay.
are a couple of comments. Excuse me, this is Doris. There are a couple of comments in the chat. So someone says Susac. Another comment about whether Adderall can also cause libido.
Okay, so I'm not sure about when somebody said Susac, I think I see who it is. Nitty, so you're dropping the bomb. You can't do that. Yeah, that's UJ's deal. So we're going to look at but Nitty, we already know you're one of the smartest people in the North American continent. So I'll just put that aside and let UJ decide where we go from there. And the answer to the second question is we do know that sympathomimetic stimulants, as well as other sympathomimetics, phenylpropanolamine, among its other problems, decongestants, that can be associated with skin patterns that you see with amantadine. So it's not mechanistically distinct, unique. It can be seen. And in fact, libido can be seen just in people who are particularly thin, very modest, young women build, who are very cold sensitive, and they come in from outside to the Froman Love Clinic, and they've got libido. But once they warm up, they get hugs, they see Teresa, it literally goes away in front of your face. So my point to you is there's a spectrum of libido that goes from, oh yeah, I've seen that when I get cold, but I'm talking about a pattern that's more persistent or maybe intensifying. That's a libido that is actually intensifying. And then the issue is it a collagen vascular? Is it drug related? Is it something else? So really good questions. Okay, UJ, I'm gonna let you keep going. Okay,
sounds good. So we'll proceed with the audiometry evaluation since this lady reported worsening hearing loss. So this is her hearing evaluation. And for people who don't look at audiograms, often I included a normal audiogram here on the right-hand side. So normally it should be kind of around or sort of near the 0 decibel line. And this is the frequency on X and hearing level in decibels on the Y axis. And blue is the left ear and red is the right ear. You don't really have to worry right now about unmasked or masked, but basically you can see there's significant hearing loss in both of her ears, worse on the right side, but the left is also affected. And this seems to be pantonal, meaning if it's affected in all frequencies.
Great point. And the other point is these are profound decibel decrements on both sides, clearly, and clearly more severe from the low to the mid, getting to the high, obviously, in the right ear versus the left. And you made the point that it was holotonic, meaning you got this at low, middle, and high frequency. Just for teaching with the residence students, if this was a patient with long-standing Meniere's disease or high drops, too much fluid in the inner ear, what you might see is loss of low frequency early, high frequency later, and relative preservation of mid frequencies. So it has this sort of, if you connect the dots, it looks kind of like a mountain or a peak. So for Lindsay and others that are in Colorado, that's referred to as the Pikes Peak. It is the Pikes Peak audiogram. And while not absolutely specific, it's very suggestive of an inner ear fluid problem. Obviously not the case here. This is a double decrement and it's profound.
Great, thank you. So additional workup and what we decided to do. So she underwent MRA of her head and neck to look at her blood vessels, and that was normal. She also underwent a black blood MRA where you basically subtract a fluid, so you can really see the vessel walls really well, and that showed a number of linear foci enhancement, which was felt to be compatible with abnormal small vessel walls, which we were worried about. She also underwent a brain biopsy, which was unfortunately normal or non-diagnostic.
Location, where was that biopsy taken from?
It was a right frontal.
Okay, and we'll just remember that the conspiguity you beautifully illustrated earlier was principally right parietal white matter and deeper than periventricular, particularly those conspicuous 4 hyperintense dots. So, and you have to pick your poison, and there's consequences for biopsy. So I'm not making any dispersion or illusion about appropriate or not. I'm just saying the money was somewhere else, and a negative biopsy does not militate against a definitive process being present somewhere else. By the way, that's a modification of something Galetta once said to me when he spanked me for thinking that a negative outcome did not exclude the diagnosis I was considering. I'll remind you, Steve, what that was later, but Uncle Steve has been teaching us things for years. Keep going, UJ.
Okay, sure. So she received
Can I just
5
make
days.
a quick comment?
Sure.
Yeah.
Sorry, this is Scott Newsom. Can I just make a quick comment about the black blood imaging?
Yeah.
So that was done specifically to try to identify a vessel that was involved. And from my understanding, when she underwent the biopsy, the MR-guided technology sort of failed us. And I think that they missed the vessel of interest. And it's important because this black blood imaging is actually, I think, an emerging technology for brain biopsies, especially when you're considering a vasculitis. But to Elliot's point, just because the person has a negative brain biopsy doesn't mean that they don't have a vasculitis or, other pathology, because it is about, how much tissue you get, region of interest, et cetera.
That's a beautiful thing, Scotty. I also know we have Leora Freeman on from Houston, who is an MS neuroimmunologist, but with particular experience in neuroimaging techniques. Any further comment above Scott Newsom's comment, Leora, about black blood imaging with respect to foci of vessel identification, normal, abnormal signatures?
Well, no, just as was said previously, I think it's just trying to improve visibility and conspicuity of these lesions, especially in small vessels where we know it's usually harder to detect the vasculitic process. But no, I think it was said beautifully, and also the comments about the brain biopsy and trying to, it's not just biopsying the white matter lesions themselves, but also trying to identify the vasculitic process within the vessel wall, so I think that was well explained.
Mm-hmm. And while we don't have sufficient time to be talking about the signature angiographic patterns of vasculitis, I want to be very clear about the fact that there are some characteristic features, but they're not specific, just like having oligoclonal banding is not specific for MS. And I personally have been the recipient of a good Pachentuchas for taking classic characteristics and features on vascular imaging consistent with vasculitis that was in stroke. And my point is there are other disorders that can present in a way angiographically which are indistinguishable from the features that you see with vasculitis. I've made and misdiagnosed those cases myself, so I'm always very, very careful and a deeper thinker about this when I look at it. And there's no substitution for tissue, but you don't always have that luxury. So between spinal fluid, blood, imaging, targeted laboratory investigations, we have more help than we've ever had, but we still need something like this, UJ. The most important thing we still need is a neurologist with a pulse who's breathing, awake, and paying attention. And it's obvious that you were here, so I'm going to let you continue.
There's, I'm sorry, this is Doris, and there's 2 things in the chat that I want to make sure. So Gabrielle is wondering RVCL versus SUSAC, and then Nidhi says, did the biopsy involve any lesions seen on the MRI?
To answer the second question, I don't think the biopsy involved any of those lesions we looked at on the MRI.
Yeah, and I think we should skip the first question, even though always in the interest of people taking the time and the initiative to ask it. We're not going to diagnosis yet. This is UJ's party, so I'm gonna mute myself and let you keep going.
Sure. So after all this workup, she received 5 days of high-dose steroids and was ultimately discharged on an oral prednisone taper. And I'll show you her follow-up brain MRI in 2 months. So this is the diffusion rate imaging again, the FLAIR, and here are finally some good sagittal images, which we were originally missing. So here I try to have like a similar cut, and basically the diffusion restricted punctate lesions are gone, and she still does have some white matter changes. You can see kind of linearly here. Interestingly, what we noted on the sagittal images, so we've got a FLAIR up here and then a T1 here, you can see corpus callosal lesions. I'll point them out here. There's a big one here and a smaller one behind. And on the T1, you can see these hypointense dots, and that shows that there has been some tissue destruction in the corpus callosum.
And there is a differential for these. We know that there are disorders that preferentially have a proclivity for involving the commissural pathway. But on the bottom image that you have there, UJ, those tiny little little bites out of the body of the corpus callosum, which we can see in this disorder, other disorders. But there's another disorder, Peter. I know Peter Sweeten is on. What about other disorders in the differential that would give rise to this sort of like very distinctive little cavitary sort of cookie bites out of the corpus callosum? What other concerns or differential diagnostic considerations would you have? Oh, he may have stepped away. So
I'm sorry.
Let me. Oh, yeah.
There.
Oh, hi, Peter.
Sorry, I was kind of in and out there. I didn't know if Susak syndrome had been mentioned.
It mentioned. What would else be on the differential for these little cookie bites?
Cookie bites. I mean, sarcoidosis could give you a similar appearance. Not necessarily cookie bites, but Marcia Favi, Bignami.
Bingo. Right. So, which used to be described, right, in Italians who drank, Italian men who drank crude red wine, and that's BS. Any alcohol will do, and excessive alcohol is an antecedent. And yeah, men can do it, women can do it, but right, Marcia Fava Bignami would be on the list. This is an 18-year-old girl. This is not that, but I just want to make sure when you see this that you're thinking broadly with respect to the issue here. And you can also see the thinning and atrophy of the posterior 1/3 of of the body of the corpus callosum. And you can see that splenium in the back, which is what UJ was pointing out in the upper image, right? There's that sort of subtle tuft hyperintensity. And maybe at the genu, at the subependymal zone, at the upper one, you see that little tiny bright dot that sometimes can fool you in terms of, is it real, is it normal, is it abnormal? But oftentimes when they begin to become more linear, which are essentially capitulating the trajectory and the morphology of the small veins, then it becomes more evident that that's a true lesion. Okay, UJ, I'll let you finish. I know we're running behind on time, but very instructive case.
Sure. So ultimately, we did diagnose her with Susak syndrome, and I'm going to briefly review that diagnosis and also kind of try to have some time to talk about management considerations moving forward. So Susak syndrome, which a lot of people know already, is typically a triad of encephalopathy, hearing loss, and branch retinal artery occlusions. It was first, well, not really first, but traditionally, first described by Dr. Susak in 1979, where he reported 2 female patients who had these 3 symptoms, and he reported characteristic findings on fundoscopy. So the clinical phenotype, again, this is all from a nice review in Nature Reviews in 2013, where they looked at up to then about 300 cases of reported Susak syndrome. The most predominant presenting symptom is encephalopathy. And you can see kind of various disturbances patients may have. But there are also various other presentations, CNS presentations. Visual disturbance was also pretty common, and hearing loss as well. What was interesting from their study was that the full triad was only manifested at presentation in 13% of these cases. So there was typically a delay between the first symptom and the complete triad, and that delay was on average 21 weeks. The clear pathogenesis of Tay-Sachs syndrome is not known, but it's felt to be some sort of immune-mediated endotheliopathy and microangiopathy. And there's a nice little cartoon on the left here, which is a model of the pathogenesis. It's an endothelial cell, and you can see that the basement membrane is swollen, and the vessel is leaking here. There's also some minimal lymphocytic infiltration of the blood vessel wall, and then you can see kind of thrombotic material within the lumen of the small vessel, and this is what causes the occlusion of the vessel and the infarcts. And here's some illustrated kind of brain biopsy specimens. Some features included dilated venules, some endothelial cell necrosis, which you can see on these two images as well.
Yujay, if you go back one, as long as you have a component analysis of the histopathological substrate of the lesion, could you make some comment about what a gas plaque is? We didn't definitively look at this on your fundoscopic photographs, but it's another characteristic feature that's present in many who have Tay-Sachs, the so-called gas plaque, and the question has been, what's the histopathological composition of that?
Oh, are you talking about this one right here?
That's what I'm asking you. In terms of,
oh, okay. So this is specifically looking at complement activation, actually. So they're staining for CD4 within the capillaries.
And then Laura, Steve, do you guys want to make any comments about the underpinning of gas plaques that are seen on the fundoscopic exam? But what do they look like histopathologically, and what's their composition?
Yeah, Steve stepped out, so. I don't have much to add, except this is a great case, and I'm stalking for the Journal of Neuro-Ophthalmology, so.
I know you are, yeah.
I know.
Yeah. So Yujay, if this is in a small branch, branch retinal artery, and you've got this little rice seed, so this is more central, the shade came down, you might have think, Hollenhorst, but these are a bit more peripheral along the segmental changes of the vessels, and they're intravascular and probably represent the compositional elements of thrombus and some of these other elements, and it is a concomitant and a frequent concomitant in those where you see the branch retinal artery occlusion clouds, and that's very conspicuous. But if you drill down and look at the vessels very, very carefully, you can see these so-called GASS gas plaques.
Oh, interesting. Okay, that's good to know. The epidemiology of Tay-Sachs syndrome, I got this again from that review paper, but age of presentation is very wide, but the mean is 30, and great majority of patients fall between that 25 to 40-year-old category. There's a female predominance with many of these presumed autoimmune disorders. For diagnostics, interestingly, the fluorescein angiogram is abnormal in 99% of individuals, even if they do not report any vision changes. And audiometry is also abnormal in the majority of patients. And typically it's low to mid-tonal, but could be pantonal. And we talked about the MRI showing characteristic callosal lesions. And interestingly, cerebral angiogram was performed in some of these cases and was normal in the majority of them. And here I have a little histogram from the same review that looked at where the abnormalities on the brain MRI were. Again, the vast majority were in the corpus callosum, but next up was periventricular areas and a whole slew of other locations as well. You can see here. There is a proposed diagnostic criteria from 2016 by the, I think, European Consortium of Tay-Sachs syndrome, but basically splitting into definitive, probable, and possible Tay-Sachs syndrome diagnosis. And basically, you need clinical manifestations and diagnostic evidence with either fundoscopy or a hearing test. And due to time, I won't go into detail. I made this chart to kind of see what's different between Susac syndrome and multiple sclerosis, because I did find a few cases in literature of individuals who had Susac syndrome who were mistakenly diagnosed with multiple sclerosis, and 2 of them were started on disease-modifying therapy for MS and actually had some worsening symptoms. So it's important to distinguish between the 2 entities. Susac typically has encephalopathy as a very common initial manifestation, and encephalopathy is uncommon in MS. For visual impairment, Susac, with the changes we've already talked about, with MS, you don't see those same changes, but rather most commonly optic neuritis. Hearing impairment, much more common in Susac syndrome. And the corpus callosal lesions look a bit different as well. For Susac syndrome, you have this snowball lesion, which is kind of what we saw earlier in our patient image, and it's typically central, versus in MS, it's more peripheral, more perpendicular to the ventricle, and kind of form out into these Dawson's fingers. The MRI lesions in the white matter are also different. In Susac, they're more punctate, as in our patient. In MS, they're typically larger, more ovoid. And then looking at oligoclonal bands and IgG synthesis in the CSF, it's uncommon in Susac, but has been reported in 1 or 2 cases, and much more commonly so in MS. So it's not like a rule-out test, but something to consider in the differential diagnosis.
Thank you for that table. That was lovely.
Of course. Prognosis-wise, it's pretty varied. Average individuals typically have 2.5 relapses and about 2 years of active disease. And there was a proposed stratification into monocyclic, polycyclic, and chronic continuous forms of the disease. And we'll kind of talk about what happened with our patient. Treatment-wise, we only really have retrospective reviews and case reports, but various immune therapies have been reported to be used, and most do respond to immune therapy. For our patient, she unfortunately had recurrent episodes of encephalopathy. So she's currently 21 years old. She was 18 when she presented, so it's been 3 years. She's had about 3 encephalopathic episodes. She also has had recurrent retinal occlusions and vasculitic changes noted on fluorescein angiogram on follow-up, and her vision has deteriorated over time. Her hearing loss has progressively worsened, and she has been, unfortunately, pretty refractory to treatment. So she has previously tried azathioprine and about 7 cycles of cyclophosphamide. However, she continued to progress, and currently she's managed on this regimen below IVIG, CellCept, and rituximab. And rituximab is dosed about every 4 to 6 months. And she was also recently hospitalized with a disseminated zoster infection. So right now, I was hoping to kind of get some faculty's feedback and input on Susac management, what have people done in the past. Any thoughts on success stories?
Yeah, so I'm going to take chair's prerogative and say we have only a couple minutes. I don't want to take time away from Ethan. He missed his presentation last time, but just because we respect and love Ethan so much, I'm going to ask Ethan to jump in and ask what would he do in this set of circumstances, and then maybe Laura, Steve Galetta, others on the call might chime in, and I will as well at the end, but very quickly in the next 3 to 5 minutes. So Ethan, what's your take on this? Any experience with Susacs?
Yeah, a bit of experience. I think one comment I wanted to make was Shashank Prasad had a really great paper published, I think it was in 2017 in Journal of Neuro-Ophthalmology. I might be wrong about the journal, but basically it was a literature search on Susac syndrome and all the cases that had been published. And what he showed was there was kind of this grouping of monocyclic and polycyclic, but that really kind of stratified by how long the patient had been followed by the time of the case published. And so in the polycyclic group, all of the patients had been followed for much longer than the monocyclic group, and the monocyclic patients had only been followed for a year or 2 years since their diagnosis. And
people in line, Ethan just gave you the definition of an ascertainment bias. Very important. Go ahead.
And so I think, for rare diseases like Susac that have only been described recently and don't have large cohort studies, to me that was a very kind of compelling argument to make that even though some patients may seem like they come in with a monophasic, illness, to me that really kind of changed my opinion that Susac is really something, even if she wasn't having these, hers is really breaking through a lot of immunotherapy, but that I would treat everybody with ongoing immunosuppression.
Beautiful. And it's just like in the pediatric age group, we don't have Brenda Banwell with us today. She's on the faculty. But, we sometimes will see a kid moving toward that transition of peds to the adult clinic who has, oh, that's ADEM, it's monophasic, you're good to go. Problem is the ascertainment is poor. Now they're in the adult clinic with Ethan and I, and it's nothing for a year or two. And then, boom, they come in with INO and a mild outflow tremor and new lesions that are symptomatic and not diagnosis. They have multiple sclerosis. So you have to be very, very much in tune with what he was just underscoring, which is the issue of ascertainment and period of time. But now on to the translation to treatment, Ethan. Have you seen anything beyond what UJ has done with this patient?
No, I mean, it's such a rare disease. I mean, we diagnosed and followed one case that I followed as a resident, and we were fortunate enough that she didn't do well with CellCept, but then eventually responded to rituximab. So, somebody who's having difficulty through a combination of 3 agents, that's a little bit advanced for me.
Yeah. Laura, do you have any pearls for us in terms of what to do or what you've seen?
Nothing to add. It's beautiful.
Yeah. Well, I'm going to take.
Can I just make one quick comment?
Oh, please. Yes.
I'm wondering about eculizumab. That's a complement inhibitor. I don't know that I've used in Susac syndrome, but just based on the mechanism of action and how it works in complementary diseases like NMO, I'm wondering if that might be something to consider given this case.
Fabulous point. There are always one here and one there, but it does drive the underscoring of how really critically important case reports continue to be, especially in rare disorders where there hasn't been any kind of systematic trial. I mean, it's very expensive to do these trials. So one has to at least think, okay, we're on some kind of immune-mediated, dysregulated disease. We know the planet. But the question is, these drugs are not all created equal. The targeting is different. We even learned the hard way in the 80s with Phil Panage's studies about, giving patients gamma interferon. We made them worse, and we know about the TNF story. So it does require quite a bit of experience, sifting, and spankings that you get over the course of these cases. And by the way, this is really urgent issues. You got a young person, everything in front of her, and yet her hearing and her vision are up in the air and at tremendous potential risk. So in a patient like this, I would be trying all kinds of things, including our regimen about IV methotrexate with leucovorin rescue. Would you consider, if you've had partial responses with some immune cell specific targeting, like with Rituxan, would you go on to Lemtrada and say, let me delete humoral as well as cellular elements and start over again? And my answer to that would be absolutely. It's part of your promise to not quit and to try. But this is very bad. Yeah.
Scott.
Elliot.
Very quickly, I just want to say, just to the eculizumab, just to remind and remember that only about 25 to 30% of these people do have antibodies, against endothelial cell antigens that have been defined, in the literature. And even, when you look at the Wilderman paper, in J neuroinflammation, even there, they're doubting whether the rituximab is helpful.
Great point. Great point. Was that
Elliot, this is Leora. I have another question for the group. I've read some case reports with Susac syndromes with treatment, on top of immune modulating therapies, association with salicylates or nimodipine. Was wondering what the group's opinion was on more vascular, type of therapies, vasodilators and such as this.
I know Andy Goodman is on. Andy, any response to Leora Freeman's comment about, do we have this wrong and we've been inappropriately telescoping on immune therapy, and maybe we ought to back up and think of this more in terms of a different mechanism, but mechanisms that combine together are more akin with stroke than they are with immune dysregulation?
Well, I don't have any experience other than using the immunotherapy like cyclophosphamide in particular with limited success in this condition. But clearly this young lady has a devastating disease. And so I think I agree with you that pursuing, other other potential mechanisms within reason makes sense to me.
Yeah, beautiful.
Fine.
Beautiful.
All right.
I think that's a good place to stop. That's a great last, and I think very candid comment. We have work to do there. UJ, would be great if we had some follow-up over time to let us know how it went and what you did, and we'll pray for the best for this young woman who I think, after what I've seen, is in superlative hands. But it'd be great to have some feedback to the group. So we're going to now transition to Ethan Meltzer, who's our MS Society fellow, also the inaugural fellow at Dell Medical School, the Department of Neurology and the MS and Neuroimmunology Center. Also turned out he was the inaugural fellow for the entire medical school. Other fellows have come, but he was the first. And I want to get the MS Society for facilitating that, particularly during a time when Teresa and I were transitioning from Southwestern to Dell Medical School. Ethan?
All right, so Ethan, this is Doris, and I just made you presenter. So go ahead and share your screen. And I just want to, UJ, I just want to draw your attention that there were some additional comments in the chat that we couldn't work in, but they might be helpful to you. So I want to make sure that you see those, okay? All right, Ethan.
All right, everybody can see my screen and hear me?
Yep, great.
All right, great.
I don't see you on the screen, but we hear you.
You don't see my screen?
No, I see your screen. I don't see you, but I see this. Yeah, that's fine.
So I wanted to take this in a slightly different direction. I mean, these have all been phenomenal cases of things that are, I think we learn a lot from, but I wanted to take it to something, maybe almost mundane in the sense that we see it all the time, but still a very kind of complex treatment challenge. And so I think it really fits with this forum. And actually is kind of interesting. UJ kind of alluded to at the very end exactly the thing that I wanted to discuss, which is a young patient who's immunosuppressed. We're doing everything we can to help their underlying neuroimmunologic disease, and then they get disseminated zoster. And so I think that opportunistic infections and what we're doing are pretty commonplace, and that was actually a pretty good representation of the question of how do we address this risk, knowing that a patient like that, who is now just 21 years old, is going to be on presumably lifelong immunosuppression, or at least the next several decades, and they're going to be at risk for infections all along the way. So because this is going to be a little bit different, there will be an introductory case, but I'm going to spend a little bit less time on the case and use it more of an example, and then go through a little bit of vaccine immunology, and then what are the opportunistic infections that we're dealing with in our clinic. And hopefully this will be, I'd love for people to jump in and kind of talk about what their own experiences are. One disclaimer with this is that, a lot of this is really, there isn't great evidence. There aren't going to be randomized trials. We're lacking a lot of rigorous data, and so this is often kind of clinic dependent or even provider dependent, but is a challenge that we're facing much more frequently at our center, and I imagine other centers are as well. So this is the gratuitous picture of Elliot Froman as a much younger man, a little bit less gray hair, and back when he was starting the MS Center at Southwestern, there was only really one FDA-approved medication. Obviously, we were using other immunosuppressants at that time, but the landscape was a little bit less complicated than it is now, as everybody knows. And what we're doing at our center, and I think is being done, really around the world, not for every patient, but for many patients, we are now jumping to these monoclonal antibodies up front, to more potent immunosuppressants up front, or we just have more patients who are ultimately ending up on these treatments. And so a large percentage of our patient population is pretty significantly immunosuppressed, and now we're dealing with all of the complications of it. Just a quick slide in terms of why do we care, besides the obvious morbidity and mortality associated, with these immunosuppressants and infections, hospitalizations, cost, but it can often can also make relapses more common and more severe. What I'm hoping to avoid talking about and discussing would be PML. Not because that problem has been solved, although I'm sure most people on this call saw the recent article in the New England Journal using CAR T cells to target JC virus and eradicating PML in 3 patients down at MD Anderson. but just because it's, we've already discussed it actually just maybe a few cases ago now with an extended interval dosing, and it's been discussed in other forums. All right, so that's my brief little intro, just to kind of set the stage for how this might be a little bit different than the usual case. So this is a patient, Mrs. O. She's 65, and she was initially diagnosed with relapsing remitting MS back in the 90s. And so she presented with a attack, was put on beta-seron, eventually switched to Avonex and then Copaxone. She then had another attack, got put on Tysabri, initially being dosed every 4 weeks. She then seroconverted to JC virus positivity, and then was put on extended interval dosing every 8 weeks. And then she and her husband, they came into clinic and really noted just progressive worsening over the past about 6 months to a year. Predominantly, it was cognitive symptoms, processing speed, memory retrieval, multitasking, the things that we really commonly see affected in our MS patients. And her exam, besides kind of a mild left INO, other elemental testing was relatively unaffected. I'm just going to include a series of images for you to see. Hopefully this video plays well on GoToMeeting. This is a sagittal T1. And as it's scrolling by, you can see fairly typical for a patient with a little bit more advanced MS, a fair amount of T1 black holes, and a fair amount of cortical atrophy, and that's really what I wanted to convey here. And then this is an axial flare. And as it goes by, you can see a few lesions in the posterior fossa involving the middle cerebellar peduncles, the pons, subcortical lesions, juxtacortical lesions. Looks fairly typical for a patient with MS. Nothing too surprising here, nothing too foreign. And try not to get into kind of a debate in terms of maybe what other providers might do. The decision that was made for her in particular was switching from Tysabri to Lemtrada. And at our center, for patients, when we're considering these medications, we get some safety screening labs. Obviously, it's a metabolic panel, CBC, but then also testing for hepatitis. You can see it was non-reactive. Varicella, the titer was reported as normal. TB testing that was negative, and HIV testing that was non-reactive. And then she's 65, and looking at her vaccination record, she had gotten her annual influenza vaccine. She had gotten her recent Tdap booster. She hadn't gotten shingles vaccination, and she'd only gotten one part of the pneumococcal series. So I kind of wanted to pause a bit and really open it up to see what other people were doing at centers, either fellows or faculty on the call. In this particular case, if you were starting this patient on Lemtrada, what would you recommend to her? So, there are several vaccinations, including the pneumococcal and the Shingrix, that are recommended for her age, independent of her immunosuppression. Are these things that you're routinely having patients do before you're putting them on potent immunotherapies? Are these things that you're trying to kind of catch up on later? She doesn't have any antibodies to hepatitis B. Is this something that you would recommend that she do? Just giving you a little bit of background on her, she's not somebody who necessarily has risk factors for contracting hepatitis.
So, Ethan, beautiful beginning. I do see there's a number of just fabulous people on the line, including Annette Okai as a colleague we work quite a lot with our patients in the Metroplex, and she's absolutely fabulous. But Annette, do you have a particular white paper? I know we sit down, we look at every patient individually, we look at the choice of the therapy, what's unique about that therapy in terms of risk and other issues. But I think Ethan's question really broadly to the group was, what are they thinking about doing in terms of risk mitigation before they start patients on intensive immunotherapy? But do you have your own sort of Baylor Medical Center in Dallas form, or what's your approach?
Sorry, I was on mute. The question was if I had my own form, what do I do in the vaccine, correct?
Yeah, what's your approach to risk mitigation before you get started? Here he's talking about Lemtrada, but it could be any of the intensive immunotherapies. But what's your approach and take on this at this point?
In terms of vaccine, normally if the titers come back and you're not immune, especially for the hepatitis B, I really consider it to be important and would recommend the vaccination for that. Shingrix, not necessarily, because with the prophylaxis, we can probably prevent that. Knowing that the Hep B takes time given the vaccination schedule, I try to get that early and not to delay care because of that. If I think it's at higher risk for that, then I'll really push for that happening. But Shingrix vaccine is all up to the patients, and because they're on viral prophylaxis, I don't push for that as hard as I would if I thought someone was at high risk for hepatitis B.
Yeah.
And I have experienced, if after the first dose of Lemtrada, later on down the line, we get the Shingrix vaccine before the second dose. And that has worked well for me. I haven't run into any issues with that, with giving the Shingrix vaccine, let's say, after a dose of Lemtrada before the second.
What about, I see Mike Levy and Ellen Mowry, both at Hopkins. Maybe I could get just a quick jump in, and then we'll let Ethan continue. But Michael and Ellen, for your patients on intensive immunotherapy, hey, whether it's TM, NMO, MS, do you guys have a particular risk mitigation strategy that you're following or beginning to assemble?
Hi,
this is Ellen.
Go ahead, Ellen.
Oh, go ahead, Michael. No, after you.
Well, I was just going to say, for NMO, we take a slightly different approach, which is we know that every relapse in NMO could be potentially devastating.
Yeah.
So we start our patients on treatment first, suppressing their immune system, and then we vaccinate them, recognizing that the vaccine may not be as effective, but it achieves a better balance of risks. And so patients who get vaccinated on treatment do better than patients who get vaccinated before treatment or patients who don't get vaccinated at all.
And you think the issue about them doing better for treatment inception followed by vaccination is at least in part, perhaps principally, related to the fact that a delay in the inception of therapy may be putting an NMO patient at risk of the next event, which could lead to permanent and monumental disability.
No, they do better. They do better than people who start treatment on time, but don't get vaccinated. And the presumption is that those who get vaccinated can avoid infections too, because the vaccine is partially effective, and those who get infected have a higher risk of relapse.
Thank you for that. That's a very, very important nuance of the therapy here, and thank you so much for being on tonight and offering that, because the approach for one is not necessarily a cookie cutter sort of approach to all, not only across diseases, but also with drugs. Ellen, what's your take?
Yeah, so I generally try for especially the B cell therapies. I personally don't use too much alemtuzumab, but for the B cell therapies, I often try to at least sneak in like a first dose, as it were, prior to initiating the B cell therapy, recognizing that we don't have too much data. Right. In terms of hepatitis B, if they're Hep B non-immune, I often would consider the same. I don't think we know as much about hepatitis A and its the impact per se, and I don't think we have a patient population that's at particularly high risk thereof, so it hasn't come up too much. I think none of what we're doing in MS anyways is very evidence-based, but we're usually able to sort of, because of insurance delays and other things, at least sneak in a dose. And whether or not that's helpful for people with MS, I don't know, but it's unlikely to be harmful.
We'll let Ethan keep going, but I just did want to underscore and pitch the fact that our group, and Ethan is leading that initiative to... Yeah, yes.
Scott, one quick thing. Let's back up for a second. The question is Lemtrada. And of those three possibilities, which is Lemtrada most likely associated with? Encapsulated organisms, HSV, or Hep B? If you only picked one.
You mean in terms of corresponding risk of having...
Of Lemtrada.
Yeah,
the
related.
recommendation is for patients with CD4 counts low, they're on acyclovir, the risk is for HSV.
Yeah.
That's the one that stands out as far as I know.
And that's why our group here actually, in our white paper, which Ethan is leading, and we had a meeting of many colleagues from around the world in Berlin at ECTRIMS, and members here who weren't there but have chimed in, like Ellen and Michael, who we will invite to be co-authors on that, and the MS Society through Kathy are going to take a look at this, and hopefully they'll endorse. But as Ellen underscored, there isn't really a lot of evidence-based medicine, but you have to start somewhere. But this is why at our place we use 2 years of continuous antiviral, antimicrobial therapy. And rather than chasing people when their CD4s are at 200, Scott, we know on this particular drug, alemtuzumab, that at 9 months, 50% of patients are in excess of a CD4 count of 200, but 50% are not. And by 12 months and moving to the second cycle, we know that 80% are, but 20% are still not over 200. So although we do lymphocyte subsets, research questions, we don't chase those patients. We give 2 years of continuous antiviral prophylaxis.
I'm not arguing for the CD4 counts being useful there, because it would be a CD8 mediated response anyway that would be helpful and beneficial. But just the point is the association was more to shingles, I think, than the other ones. That's my only point. I wasn't part of it. Sorry for being naive.
Well, not only that, yeah, if that them on prophylaxis, there might have been a trick question that because of that coverage and maybe not potentially adequate coverage for encapsulated organisms and others, they may go higher on the list because you already are prophylaxing against the really predominant, bigger problem, higher frequency issue, which is, of course, recrudescence of herpes family infections. Who was that was just asking a question?
No, I was just gonna keep moving forward. I think that that's a good point, and that I'll kind of bring up a little bit later in terms of you're talking, trying to break down the particular immunosuppressing agent and which kind of opportunistic infections that patients at higher risk, and going through is this a more of a cellular-based immune process talking about CD4 and CD8 versus a humoral process talking about B cell therapies. Okay. So maybe we'll go over this one a little bit faster, unless anybody has a kind of a strong opinion, but would be, this patient is currently on Tysabri, and whether we were switching them to Ocrevus or Lemtrada, or we just wanted them to get an influenza vaccine. In terms of, they're on 8-week dosing. If the patient were on 4-week dosing, how are we going about doing that at our centers? If they're on 8-week dosing, how is that different? Or kind of other DMTs. And I'll provide, there's a little bit of data in the MS world and then in the non-MS world in terms of vaccine response, I think that people have already alluded to, and some is better than nothing. Another thing just to kind of think about as we're talking about, and again, this was already somewhat kind of talked about and discussed with the NMO example, which is, in a different type of patient with an aggressive new presentation or with NMO, where we really don't want to delay and we don't want to do a vaccination series that takes 6 or 8 weeks to accomplish. How do we go about doing that? Is that something that's done in retrospect, just when able, or are some things actually worth delaying treatment on? So I think that's a point that was already raised. And so what I'd like to do is just kind of talk a little bit to bring kind of everybody up to speed. I know there's a lot of immunologists on the call already, but just some basics in terms of vaccine immunology and these opportunistic infections to maybe try and help us guide some of this discussion. So it really requires a response from both B cells and T cells, and a durable response at that. And part of that is boosted by adjuvants within the vaccination itself. And the T cells, essentially pre-vaccination, are at very low frequencies. They're may be antigen specific, but not at high levels. After the vaccination, they undergo this clonal expansion. And then several weeks later, they kind of prune or are contracted, and you get these effector and memory T cells that are very long lasting and essentially responsible for maintenance of memory and are in a homeostatic balance. B cells act a little bit differently. They're B cells that are hanging out in our peritoneum and our pleural cavities. These are not very specific, but they're sensitive. And these aren't really affected by vaccinations. There's also B cells hanging out in our spleen. Again, these are looking for bloodborne pathogens and maybe a little bit less specific. So these have low affinity antibodies. But when we're talking about vaccination response and a lot of these opportunistic infections that we can protect against, we're interested in this T cell dependent B cell activation, formation of plasma cells and germinal centers, and trying to get these long-lasting plasma cells and memory B cells to help us have these high affinity antibodies for particular antigens. And I think an important concept here when we're talking about getting these safety labs on patients who are coming in is the concept of a surrogate versus a correlate of immunity. So these correlates are the presence of the antibody conveys the protection. So an example would be diphtheria or tetanus. That antibody will prevent the infection. However, a surrogate of immunity is really just an indirect measurement. And so the case here, I think that's very important for our patients on certain immunosuppressants would be the presence of the varicella-zoster antibody, the IgG titer that we're commonly measuring is really just a surrogate for immunity, and actually the CD4 or actually the CD8 cell responses are better correlates to disease protection. So I just wanted to kind of go over a little bit and get input from everybody in terms of breaking down the different disease-modifying therapies and then the different infections that our patients are at risk, and maybe have a bit of a discussion about what centers are doing to help kind of avoid these risks. So for influenza, the data is really about response to vaccination because people don't really get durable immunity to influenza. Essentially going through the 3 oral medications and the 3 IVs that we think of as more commonly used in the MS population and being more potent immunosuppressants, a lot of them do have decreased humoral or cellular mediated responses to vaccination. There was a study that was published in Neurology looking at the response in MS patients on Gilenya versus MS patients on placebo to influenza and tetanus toxoid. And I think one of the take-home points here is that even though patients had a slightly attenuated response, it definitely does not go to 0. So yeah, the difference was about 80% versus 50% for the influenza vaccine after 3 weeks, and a little bit less after 6 weeks. But there still really is a durable response in many patients, if not about half, who received the vaccination. Because that's really a common question that we're getting at our center from patients is, should we get vaccines while we're on treatment? For tuberculosis, this might be just more of an issue that we deal with in Texas, where there's a little bit higher rates of TB as opposed to the Northeast. The drugs that are impacting cell-mediated immunity are more likely to be associated with activation and progression of latent TB. This data is really kind of compiled from the initial trials and the extension data when we have it, as well as the FDA inserts. But if you look, actually, the rates of tuberculosis, from what we can tell, even though they are higher in drugs like Aubagio and Lemtrada, they're still relatively low. And the cases that we're seeing were only in areas that were endemic. So this is obviously a fear anytime we put somebody on immunosuppression, but seems to be maybe relatively less common than what we might expect. But it is still something, at least in Texas, especially here in Austin, that we're looking for given the high rates of latent TB in our populations. I wanted to shift a little bit into varicella-zoster to kind of look at the differences between cellular-based immunity and humoral immunity and what we can learn for our patients here. So this is looking at an animal model with the simian varicella virus. And essentially what they have is a control group, a group that was depleted of CD20 cells, a group depleted of CD8 cells, and then one depleted of CD4 cells. And this is kind of the analog to varicella-zoster. And the monkeys with no B cells, actually, when they were infected with simian varicella virus, looked almost identical to the control group. However, the monkeys that were depleted of either CD4 or CD8 had severe infections, some of which were fatal and were often disseminated. So I think that this is kind of a good model here for us to look at the importance of what we're giving patients. So I know that we often still are getting are looking at titers of varicella zoster and thinking about it when we're giving patients Ocrevus or rituximab, but that may actually not be that high of a risk or something that we should be as concerned about. And then looking at humans on the left here, this is essentially looking at IgG titers by age to varicella zoster. You can see obviously this peaks up in childhood, either due to infection or now vaccination, and remains relatively elevated over the course of adulthood. Whereas looking here at cellular-based responses, this does seem to wane over time and is a truer marker of immunity. One comment here, just in terms of what is available to help protect our patients, is the Shingrix vaccine, which came out several years ago, is highly efficacious, especially when we compare it to the older vaccine, the Zostavax, which is a live attenuated. And so these rates of upwards of 95, 96, 97% versus only 50 to 66% is a pretty dramatic difference. And so getting to the point that was made,
particularly with duration in terms of time horizon of that efficacy is very important. Durability of the effect.
Yeah, and I think that this is really getting to the point that was made earlier. For Lemtrada in particular, we want to look at what infections are the patient really at risk for. And so for herpes zoster, I think everybody knows there are case reports of it being seen in patients on Gilenya, especially patients who are on dual immunosuppression. But it's relatively lower risk in a lot of the other DMTs, but there have been several reports of disseminated infection in patients on Tecfidera, I think generally ones who are a little bit more lymphopenic, as well as Tysabri, but the rates are pretty markedly elevated in patients on Lemtrada, and they are mildly elevated, or were seen to be elevated in at least the relapsing remitting trial looking at Ocrevus. And so, one question, that we deal with is patients who are on immunosuppression, whether or not they're going to make good responses. And we know that there's fairly limited data, especially in the MS world. And so looking at the oncology literature, there was a single phase 3 trial where they administered the Shingrix vaccine to patients who actually got autologous stem cell transplants. They actually gave a series of 4 vaccinations, 1 pre and then 3 post, and they showed that the vaccine efficacy rate was about 64% in their patient population that was vaccinated compared to the patient population that was unvaccinated, which actually is about similar to the Zostavax efficacy in the healthy control populations. So I think there is some good evidence to say that we probably are benefiting patients when we do this, even when they are suppressed. So I think that this kind of goes back to one of the things that we're dealing with at our center is why are we even checking the varicella zoster IgG titer, especially in cases when we're thinking about potent cellular immunosuppressants that are going to be affecting the T cells. So I was just kind of curious in terms of other centers what people might be doing. Are people routinely checking this and making decisions based off the presence of a positive IgG titer, or are people just giving vaccinations based off risk of a particular DMT?
So Ethan, this is Doris, and I want to draw your attention to a comment by Joshua Katz in the chat. Where he mentions what the protocol that they follow for patients on Ocrevus.
Yeah, so I'll read it. The question is for our Ocrevus patient. This is Josh Katz. That's his comment, but it's Elliot Froman reading it. Josh, why don't you chime in and why don't you read it?
Sure. So, I have to acknowledge that we don't know, what to do for patients. We've seen a number of patients who have gotten Ocrevus actually have zoster, and it's about at the rate of what they reported in the clinical trials. We're trying to get everybody the the Shingrix vaccine before, 6 weeks before they get Ocrevus, if we can. The problem, as many of you may know, it's very hard to acquire. There's been a shortage of that vaccine, And we are trying to work actually with Genentech to do a study where we can find out for people who are already on Ocrevus about the efficacy of the Shingrix vaccine, because for people who are already on it, we are going to vaccinate them, but we don't know how effective that's going to be.
Yeah, I learned some of the most important pearls from my own mistakes or debacle. So let me offer yet again another one of my mistakes, which I've done repeatedly over the last 2 years being involved with the webinar. And that is, in the past, I've looked at the serologies and looking at a patient who had a serology of 1,024 dilution for varicella zoster virus. We're good to go. Short story, they go on therapy, they develop shingles. Let's be very, very clear that the presence and the magnitude of an antibody response, lots of antibodies, does not necessarily tell you about affinity or avidity maturation, or with immune senescence over time, whether the presence of large amounts of antibodies are necessarily antibodies that still have good binding interactions at the hypervariable FAB2 fragment component. So I learned the hard way and gave myself my own Pachentuchus and said, Elliot, you can see it if you like, and we do research and ask questions, but I would vaccinate everybody, irrespective of the serology titer of the varicella zoster IgG. The question you were asking, Josh, was really about, well, what about pneumococcus and some of these others? We have a lot to learn, but particularly with respect to herpes family viruses, I would make the argument for advocating strongly for vaccination, even while patients are on antiviral prophylaxis, because as you know, when it goes bad, it can actually be cataclysmic. So there's my mistake. And just like antibody development, the presence of an antibody doesn't tell you what its interaction and its avidity, affinity characteristics are about. And those characteristics are really germane in terms of whether the antibody is functional in producing what you know it needs to do, whether it's reticuloendothelial clearance or complement-dependent cellular cytotoxicity to get rid of those cells or the virus.
Yeah, and so, in trying to figure out whether or not the Shingrix vaccine is effective in patients who have already been treated with Ocrevus, checking VZV titers is useless. That's not going to tell us whether or not they develop an active immunity.
I'm with you 100%. We're on the same page. I'm with you. Until we have other data, but I totally agree. That would be my assumption.
Yep.
And
Okay.
I think that, the other challenge with that, of course, is is the variable recovery of B cell of CD20 cells, CD19 cells after receiving Ocrevus, and one patient may be if you're doing it every 6 months, they may have a still 0% of their B cell line. And so it might be hard to really say definitively whether vaccination is going to be helpful or not in that population. You have to really kind of screen to make sure, if we even think they could mount a response.
Yeah, and by the way, that's a very important comment, because it also gets to the issue of immunology 101 without picking on anybody. It's not like you got polio guys and you've got plasmablasts and plasma cells. You got factories for life. That's not what we're talking about. What Ethan just underscored is the critical principle. The very same sorts of population repertoires that are autoimmune and go after you and are evolving and epitope spreading, when it comes time to have a vaccination that has effectiveness, you have to go through that pre-B cell lineage and its transformation genetically and otherwise in order to produce competent antibodies. So this is not plasmablast or plasma cells, measles, polio. We're not redoing that. It's lifelong. These are much more dynamically shifting patterns of immunity, and we need more evidence-based medicine, but it's a problem, and we should assume that we're in for potential trouble. And if we're not, great. But that's why we're having this conversation.
This is Doris, and I also want to draw attention again back to the chat, where we have some comments and some questions from Dr. Baines. And so
Lori, do you want to go ahead and just read the question? Go for it. Yeah. Or maybe there's a mute issue. Well, it says we've been recommending booster shots thus far at least 2 weeks prior to starting medication. So there's at least 2 issues there, Ethan, you may want to address. One is the issue of booster. The second one is the latency between boosting immunization with adjuvant before starting an intensive immunotherapy.
Yeah, and I think that really gets back again to the mechanism of the immunotherapy, and if we have time, there's when looking for data, there's not too much. There are some guidelines from the IDSA, the Infectious Disease Society of America, in terms of when the timing to give vaccinations prior to immunotherapy, and it does seem like having the 2-week window is the minimum and is probably enough time to mount some response, but I think it does come back again to what type of immunotherapy you're starting. If it's something like Ocrevus or rituximab versus something like Gilenya, there's obviously going to be a little bit of a differential response.
Very important comment. Okay, we'll keep going. And by the way, in the matter of time, it's about 6:17, something like that. So we're going to keep going. I know people may have to drop off, but Ethan, I really want to have the opportunity for you to get through the main of your set. You produced a fabulous presentation. I've seen part of it up.
Yeah.
The whole thing.
I'll wrap up in the next 2 or 3 minutes.
Excellent.
Yeah, so I think that herpes simplex, again, in terms of the herpes virus family, it's going to be a similar story to what we're thinking about when we're thinking about the zoster. Hepatitis, I think, is interesting because this is one of the infections that was generally an exclusion criteria in some of the trials, especially the ones that are targeting B cells, and with this very high risk of reactivation when we're suppressing humoral immunity. We can actually look, though, at the oncology literature, which I think has some interesting studies. There was 2 randomized trials done. So in patients with lymphoma who essentially need to be on rituximab, and in patients who have been exposed to hepatitis B previously, they randomized patients to either receiving prophylactic lamivudine or getting placebo. And in one trial, there was a 0% rate of reactivation on prophylactic lamivudine, and the other trial, I think there were 20 people, and there was only 1 patient who had reactivation, compared to about a 60% reactivation rate in patients on B cell treatments. And I think what was the important take home I get from that, and maybe this isn't applicable to MS patients because we have so many options, but in NMO patients, something that might, at least in my mind, was previously a contraindication, would be prior exposure to hepatitis B, might actually be something that we can work through. And I think one other important note about this is that in the patients who did have reactivation, 60% in the placebo group, none of it was actually associated with any significant morbidity or mortality. So they were monitoring LFTs monthly, and they did start to see a rise, but then they were able to initiate treatment, and there wasn't any harm done to patients in the long term. And so I was a little bit curious if anybody had had experience doing this in the MS world. I hadn't really seen it previously.
Scott?
Elliot, what would you like me to say? I'm here.
Have you had any experience with that is really the question.
No.
Okay.
Simple answer. But I have other thoughts later.
Okay. Elliot?
Yes, please.
Elliot, this is Leora, and I actually have a couple patients that came back with actually positive, not antigen, but positive core antibodies for Hep B, and so and one of them was, my first one was initially an NMO patient. So that's where the question was, really to want to put her on B-cell therapy, and I worked with a hepatic transplant specialist and we decided to get her on, I think it was not just lamivudine, but a prophylactic, just a combination of two antivirals for Hep B, and we started her on rituximab, and she's been doing well. I now have a young MS patient who has failed injectables, failed Tecfidera. One of the choices was to put him on Ocrevus, and that's when we found out he also had core antibodies for Hep B. I'm still waiting to hear back from his workup, and I was thinking of putting him on Ocrevus, but also thought that, we do know that a lot of our MS patients that are, for instance, on an oral like Gilenya, which would be an alternative for this patient as well, have very low circulating B cells, I was wondering if possibly the risk that we see for Hep B reactivation could possibly be seen in a patient like this treated with another medication than ocrelizumab. So I'm, kind of waiting and working currently with the hepatics, specialist to maybe initiate some kind of prophylactic treatment before starting him on either Ocrevus or possibly Gilenya in this case. So I can give you guys, once I have a little more experience with that, I may be able to update you.
Let me just reveal and disclose something important. That is that Leora is down at UT Houston, but prior to that time trained and then was fellowship and working in Paris. And of course, the French represent the Mecca epicenter of the entire controversy around hepatitis B in particular. We know that. So your colleagues, your mentors, there's been an ongoing discussion for a while, and a lot of papers actually out there about is it safe or is it not over the years. One thing about your patient I would ask is, was this patient assessed for any evidence of hypogammaglobulinemia? Raises the specter of that if titers don't come up with immunization, whatever it may be, would you have a patient who is on 6-month latency infusions of Ocrevus, but punctuated somewhere in the middle, potentially by the administration of gamma globulin? And I'll leave it to you in terms of either commenting or not, or something we can get back to later. But I think the investigation to also know something about the baseline immunity of our patients and what is their ability to mount, develop, somatically hypermutate, class switch, avidity, and affinity maturation, may be different among different patients. I find the more we look, the more hypogammaglobulinemia we're finding. And that does raise the specter in terms of, okay, is it actionable? And the answer to that is, of course, shortly the answer is, I don't know. The longer answer is, perhaps. And then I think we get to issues of strategy, and that may be one. Obviously, you'd want to do it not too close because gamma globulin has also the ability to produce anti-idiotypic blocking, and you don't want to do that on a very expensive and efficacious immunotherapy you've just administered to your patient. So these are the big league questions. Your point is a very good one. It'd be great to get back to this Hep B story at some point in our webinar series. It's a big story, and most of it occurred really in Paris in terms of things we learned. Okay, Ethan?
Yeah. Maybe I'll just skip. Well, maybe I'll end with this one in terms of kind of one of the last big opportunistic infections that we think of in our patient population would be streptococcal pneumonia. And really, I think the literature right now, and I'd be interested in other people's take. For me, it may seem a little bit less about the particular disease-modifying therapy and more about a patient's individual risk factor. And so, much higher rates were seen in the trials for ocrelizumab and Lemtrada. However, those patient populations also had much higher EDSS scores. They were much more likely to be in wheelchairs, to be non-ambulatory, or to be in bed, and so and also were older. And so I think that maybe part of the risk with this is yes, they are immunosuppressed and the rates are slightly higher, but maybe this is something that should just be thought about more frequently in all of our patients. And this is actually the one opportunistic infection that has guidelines from the last time it was put out by the AAN, which was 2002. Which does recommend the pneumococcal vaccine for these types of patients.
Before you end, I can't let this go. Jenny Fang took the time to write this out. It was, Hep C patients were excluded from the original ocrelizumab trials, and the question was, what do you do for hepatitis C antibody positivity in somebody that you're wanting, to start on ocrelizumab? So you want to comment about that, Ethan, or anybody else on the phone in terms of what your take is on that particular issue?
Yeah, I think that that might be both easier and harder in some way, and that there is now approved treatment for hepatitis C. We haven't come across that yet in one of our patients, but I think the treatment course for that, I believe, maybe somebody could correct me, is 3 months, and it's at least several months. But once that's completed, the patient, that risk is then gone, and the patient could then be treated with something like ocrelizumab.
This
good
is
point.
Ellen. I actually tried to look at the literature about hepatitis C for a particular issue, and there really isn't too much information on hep C in the B-cell therapy, as best I could tell, but I did find several places in which people with hep C cryoglobulinemia were treated with B-cell therapies, actually. So my sense is perhaps we don't need to worry about hep C as much. However, I think it's always nice to clear infection somehow before we slap people with immunotherapies, but it may be more of like just comforting ourselves rather than actually very evidence-based.
And I am concerned that
So
you're
this is
getting
Annette.
yeah.
I just had this experience a few months ago where hepatitis C showed up, and I did refer them to GI, and they were treated with therapy, and for, I don't know if it was 3 months, Ethan. I think it was up to 6 months, and the hepatologist said that after that therapy, they were okay to start back on their B-cell therapy. So he said it was no problem to go ahead and treat them. So I would err on the side of caution if I come across this again, to have the patient treated for hep C and then restart or start their therapy.
Well, that's a really great comment. Thank you for that, Annette. Ethan?
Yeah,
Closing comment?
No, I think that, a lot of people have made really good comments, and it really comes down to, something that I think we're doing and a lot of other centers are doing, which is acknowledging the fact that when we have patients who come in, like the SUSAC patient who was just presented, upfront knowing that they are going to be on long-term immunosuppression, whether they're on something that is very potent at first or not, that may not be as relevant, but really trying to get ahead of the ball and do everything we can to lower this risk with either vaccinations, prophylactic medications when it's necessary, and really incorporating that into kind of part of our initial intake.
I think that's a perfect place to line punctuate and to stop. That was fabulous, and thank you for it. I know we got started a little bit late, but it was great getting through it, but also to encourage the degree of participation. I think, Kathy, if you're still on the line, I think what you're seeing is not only folks jumping in and asking, there's been a lot of chat questions being written. I think there's a really nice balance emerging in terms of people coming and not to hear themselves talk, but they really want to take something away to learn, but as in Annette's final comment, to contribute experience, which really is important, particularly Ellen, where we don't have a lot. That was a nice way of putting it. Not a lot of evidence-based medicine. It's almost like squat. And we would sleep better if we knew more about what these issues are in our individual patients and what really is the best thing to do for them, because we're doing so much better in treating these patients now, better than ever. Incredible where we are. However, of course, there are these corresponding issues that we have to deal with, that we pay a price for, as do our gastroenterology and dermatology, other colleagues who have been doing it actually a lot longer than us, but we do have to address it. So any other final comments? Housekeeping, Doris or Kathy?
No, that is it. Thank you so much. This is recorded, and I will send out the recording link in the next couple of days, and it'll be posted on the website.
Okay, fabulous, Ethan. Really
great
terrific.
job, everyone. Yeah, totally.
Okay. Have a great evening, everybody. Thanks so much.
Good night. Bye-bye.